Hello, welcome everyone. Um, it's good to have us here. We'll just wait for other persons to join and we'll be starting at 7 on the dot. So if you're inside of the call, just ensure that you keep your mic muted, and it would be better to leave your video turned off for now. Thank you so much. I see our speaker is already in the house, in the waiting room. And so we're going to start very early. And trust me, you do not want to miss any part of today's session. So you certainly want to stay tight to your system, to your phone, get your jotting pen and your notebooks, and be sure to put things down when we start. Welcome, Dr. Zeina.
Destiny, how are you?
I'm very
Long
fine,
time no
very,
see.
very fine,
How are you doing? It
very
has been
fine, very
a
fine.
long time since we
Same
contact.
here.
How's everything? All is good?
Yeah, very good, very
You're
good.
studying, your preparation, everything is going well.
Very well.
Excellent,
Very,
excellent. Thank
thank
you
you.
for inviting me again for this. I'm so happy to
Uh,
be here to you
it's
today.
always a pleasure. It's always a pleasure. Thank you so much, Dr.
Actually,
Zena.
it's my pleasure to be here, to be with you in this series year after year. I'm so happy that you're holding this every year. It's really amazing. Your perseverance is
Thank you.
amazing, astonishing. Wallah.
Thank you.
Okay, so until we
Yes,
start, we still have 15 minutes. Maybe if those who want to drop on the chat box where they are joining us from, so we can start having an idea what who are where are they attending, joining us from.
exactly. That makes perfect sense. So, good day,
Right.
everyone. Good morning, good afternoon, good evening, depending on where you're joining us from. So, it's the first day of our 9 session series, the first of its kind for this year. And we're going to be starting right now with the introduction right here inside of the call. So you want to head to the chat box and tell us where you're joining us from, country, your name. You want to tell us your interest in pharmacogenomics. We want to hear them. We want to see what's more join this to register, to make out that time to be here. I understand that there are persons from Pakistan, there are persons from um, even India, and now it would be around 11 p.m. in their side. So, what your motivation is to be able to join this webinar series time, just name and the place you're joining us from. Thank you. So while you do that, I'll just put up the bio of our speaker so we can have a look at that as well before we start properly. So just your name and the country from which you're joining us in the chat box, as well as your motivation to being here. Okay, so I'm going to be sharing my screen now and just, yeah. Okay, we want to see the chat box. I want to see your name, the country you're joining us from, your motivation for being here to be part of this webinar series, despite the fact that there are a lot of odds that could have prevented you from being here, or you've decided to be here anyway. So just give us those reasons in the chat box. Okay, I see some messages in the chat box already. I see Eugene from Rwanda. Eugene is interested in precision medicine advancements. That's great, Eugene. It's great to have you join us. It's really amazing to have you join us. I see Wesley from Kenya, a student doing biomedical science and technology. It's great to have you. It's great to have you join us. I see Mobita. I see Mobita from Namibia, interested in pharmacogenomics, precision medicine, networking, and collaboration. That's really nice. That's really nice. That's really nice. That's really nice. Nice meeting you too, Eugene. It's nice meeting you. Okay, I see Chance from Rwanda, interested in learning more about precision medicine. It's great to see these wonderful comments. It's great to see them. Let's keep them pouring in. Let's keep them pouring in, guys. We're going to be starting by 7 on the dot. Okay, I see Abraham from Zambia, a student of pharmacy interested in pharmacogenomics and precision medicine. That's amazing. That's amazing. It's great to see that, Abraham. Um, Perhaps part of the questions we'll be able to answer today, which I think we're not able to answer during the last session, is how much pharmacogenomics and precision medicine is actually integrated into the pharmacy curriculum for pharmacy schools, especially here in Africa and other LMICs. So perhaps we'll be able to get insights from our participants today. I see Maghrabi, a PhD student in immunology from Syria. It's great to have you join us, Magabi. I'm sorry if I mispronounced that name. He says, or she says, sorry, Dr. Zeina is a dear friend and colleague. I'm a keen follower of her great work, and it's encouraging me to get more involved in precision medicine. Oh, that's amazing. That's amazing. just like myself and so many others. Yeah, Dr. Zena has been a very, very great source of inspiration for so many persons around the world. I can say that very, very well. So I share your thoughts, Sulaf. I share your thoughts as well. I see Nishat from Pakistan, interested in clinical pharmacogenomics. That's amazing. That's amazing. Nishat, it's great to have you join us. It's great to have you join us. Let's keep them coming in, guys. Let's keep them coming in. So we're going to be starting as soon as it is 7. Let me check my time. Okay, let's keep the comments coming in. Let's keep the comments coming in. Introduction, your name and the country from which you're joining us, as well as your interest in pharmacogenomics. What has made you to make out the time to be here at this time? We want to see them. Okay. Okay, we have about about 8 minutes to 7. So let's just take the time to introduce ourselves in the chat box. Okay, I see Dr. Daram Raj. Daram Raj, I'm sorry if I mispronounced that, a consultant, drug specialist, and clinical pharmacologist, also a PGS consultant from India. Well, that's amazing. That's amazing. It's great to have you join us, Doctor. I'm interested in gaining more knowledge and people related, okay, to pharmacogenomics and precision medicine. That's amazing. That's amazing. We all want to connect. I want to connect with you as well, Doctor. The amazing work you guys have been doing in India, it speaks very loud. Thank you so much for joining us. I see Yahaya Uma. Yahaya Uma, okay, you didn't tell us what country you're joining us from. Yahaya Uma teaches genetics and precision nursing in the Department of Nursing and a nursing researcher and clinician with interest in genetics and oncology nursing. Well, that's amazing. That's amazing, Yahaya Uma. It's great to have you join us. I would love to know the country from which you're joining us from. If you can hear me, I would really love to know that. It's very nice to see that genetics and precision medicine is gaining ground in our healthcare space. And I love it when I see that it's not just pharmacy students or pharmacists who are in these meetings. We also have nurses, we also have medical doctors, we have other healthcare specialists who are here with us. It's really amazing. It's really amazing. Okay, Yahaya Uma is from Nigeria. That's amazing. That's amazing. It's great to have you join us. It's really nice to have you join us. Let's keep the introduction coming in, guys. Let's keep it coming in. Okay, I think I missed some of them. I see Haya from Syria, a biotechnology engineer and bioinformatics analyst, very interested in precision medicine. That's amazing, Haya. It's great to have you join us. It's really great to have you join us. Thank you, thank you, thank you. We still have about 6 minutes to go, and we will be all set. Dr. Zena, can you see my screen just to confirm? Is my screen still
Yes,
showing?
yes,
Okay.
yes, it's showing.
Great, great. Okay. Let's keep the introduction coming in, guys. Let's keep it coming in. We'll be starting in about 5 minutes. Okay, let's keep it coming in, guys. Let's keep it coming in. Okay, I see there's a number of persons in the waiting room. Let's admit them now. Okay, okay, I see Silas, pharmacy student from the University of Rwanda. That's amazing. It's great to have you join us, Silas. It's really great to have you join us. Um, here. I think the person's in the waiting room. Okay. Okay, I see Bosse, a student pharmacist at the University of Nigeria, Nsukka, Enugu State. It's great to have you join us, Bosse. We are really grateful to have you join us. And it's really interesting to see how much interest that a lot of us have in pharmacogenomics and precision medicine. And it's really amazing to have you join us. Good evening, Oratile. Welcome. I'm sorry if I mispronounced that. It's good to have you join us. Starting in about 3 minutes, I think, from now. Yeah, 3 minutes. So you still have the chance to share with us where you're joining us. For those of us who just joined us now, you can use the chat box. Just tell us your name, the country from which you're joining us, and the reason for which you've decided to be at this meeting, rather than be somewhere else, rather than just be sleeping or doing something else entirely. Why did you choose to be here? What's the motivation? And like I mentioned earlier, I understand that a good number of us are from Pakistan, from India, and we are still here, even though currently in India it should be around 11 p.m. So there must be something that has motivated you to be here. We want you to share that with us in the chat box while we wait to start by 7 on the dot. Okay, I see Nethonondo, a pharmacy student from Health Science University, South Africa. It's great to have you join us. It's great to have you join us. I see Akinkemi Clement, a medical student from the Federal University of Health Science, Nigeria. Thank you so much, Clement, for joining us. Good evening, Ominisi. Thank you for joining us. I see Moswani. I'm sorry if I mispronounced that, from South Africa, Health Science University, South Africa. Okay. Ominisi is from University of Abuja, Nigeria. Thank you so much for joining us. I see Faith. Faith, good evening. It's great to have you join us. So while we keep the chats coming in, just keep the introduction pouring in, we're going to right now move to introduce our speaker, our guest speaker for today. Ladies and gentlemen, our guest speaker for today is someone that is not a stranger. Yes, she's someone that has been with us since we started PharmaGenoXfE up until this moment, through the struggles, through all it is we've been doing. She has been with us. She has been with us. And I would like all of us to give a round of applause to our speaker. I want to see the fire emojis. I want to see the dancing emojis. Just any way you can express that appreciation to our speaker. Let's keep them pouring in before I go on to read her bio. Thank you so much. So I'll be introducing our speaker now. Our speaker for today, being the first day of our Precision Medicine in Practice from Genomics to Real World Impact series, which of course is the first series we are having for this year, 2026. And the topic for today's session is Precision Medicine Beyond the Buzzwords. Where are we really headed? So there's been a lot of talks about precision medicine, about pharmacogenomics, about the place of precision medicine in healthcare. Is it supposed to be given so much attention? How much attention should we give to it? Where are we headed with precision medicine? Where is the future of healthcare going to? These are the questions that we're going to be answering in this session today. And we have no other person than the amazing Dr. Zeina to help us deal justice to this topic today. And Dr. Zeina is an assistant professor of genetics at the Abu Dhabi University's College of Health Sciences, where she integrates her expertise in genomics into teaching and research. She's a distinguished pharmacogenomics scientist, and she holds a PhD in pharmacogenomics from the United Arab Emirates University, and has contributed significantly to uncovering rare and novel pharmacogenetic variants in Arab populations. Her research is widely recognized with multiple publications in prestigious international journals. Dr. Zeina has received advanced training in medical education through Harvard Medical School's teaching in medicine program, enhancing her innovative approach to precision medicine education. She's an active member of the International Pharmacogenomics Consortia. She's an active member of International Pharmacogenomics Consortia, including CPEC and PharmVer, and holds editorial roles in scientific journals. Additionally, she leads the IVPN Personalized Medicine Initiatives, focusing on expanding pharmacogenomics education and its clinical implementation, particularly in the Middle East. Now, ladies and gentlemen, you can clearly see that the speaker that we have for today is indeed an amazing speaker. And with a round of applause, with the fire emoji, with the emojis that you want to express your gratitude, just use the chat box and welcome our guest speaker for today, Dr. Zeina.
Thank you. Thank you.
Thank you so
Thank you,
much,
Destiny,
Dr.
for
Zeina.
this very generous introduction.
Yeah, I would
And
stop
really,
sharing
it's
my
my
slides
pleasure
now.
and my honor also to be here with you for the third year. And I'm so happy to start and initiate this series. You are just an amazing scientist. That is every day, every year, you are like more enhancing your efforts and putting more and more efforts for this. So I'm really happy to support your efforts, and I hope that we together we can make the future of precision medicine the future that we deserve, and everyone who is caring of increasing or improving the practice is also enjoys. So for now, can I share my screen for the presentation?
Absolutely, you
Yeah,
can share your
thank
screen.
you. Okay, so hi everyone, and I'm really glad that I'm here today. Thank you all for being here. It's now 10 p.m. here in UAE, where I am joining you from. And it's amazing to see all these people from around the world, one who are even later from India, Pakistan. They are behind also, maybe 11 or later on. And some also in there after your work from Africa. So I'm really glad that you are here, and really grateful for this opportunity to meet you. So as Destiny has already told you about, and with a great introduction about today's lecture, or let's say talk. So our discussion today will be titled Precision Medicine Beyond the Buzzwords. And maybe you are asking now, why should I care what is beyond this buzz? Is it a buzzword actually? Why I am here? So indeed, precision medicine is actually usually is overhyped. So this leads to multiple misconceptions. And today's talk is a main aim is to establish a solid foundation for you and for the majority of you maybe are young professionals to understand its true potential and practical implications. And maybe by now you know me, but let's also introduce why I am telling you this, or why I can tell you about this subject. Because as Destiny has mentioned before a few minutes, that I am a researcher in pharmacogenomics with more than 30 peer-reviewed articles or publications in pharmacogenomics. And I focus mainly on underrepresented populations And all my efforts for the last more than decade has been on teaching and implementation across academia and practice, implementation mainly of pharmacogenomics. So this is a little bit of my profile. So let's dig into the subject. What is precision medicine? So precision medicine, it involves adapting medical care to the unique characteristic of each patient, including their genes, environment, and lifestyle, instead of using one-size-fits-all approach. So I think this is not the first time, I guess this is not the first time you hear this definition. However, I hope that we go deeper during this talk to the real essence of precision medicine. So by this definition, actually, it involves, that precision medicine includes mainly pharmacogenomics, which is my specialty, but it's not only it doesn't only include pharmacogenomics, because precision medicine involves also cancer-targeted therapies. These therapies that were not being possible to be designed unless we understood the molecular basis or the molecular changes with some cancers. And also, so we get more precise to the treatment. And also immunotherapeutics, which target or which have the aim of enhancing the immunity to fight cancer. So like guiding the immunity against cancer. And also, it includes rare disease genetics and rare disease treatments, that these treatments that have been designed specifically for a handful number of patients suffering from rare diseases, and multi-omics integration. And by reaching to the multi-omics integration, here we are considering not only pharmacogenomics, we are considering the environment, the microbiomics, we are considering the different transcriptomics and how they are affected by the different environmental factors and maybe metabolomics. So all these levels of omics, integrating them into getting data more specialized and more precise to this specific individual, all of this is under the umbrella of precision medicine. However, my talk today will be more focusing on my area of interest and my area of research, which is pharmacogenomics. So why should we care about precision medicine? What does precision medicine promise us and promise healthcare with? So we can say that there are three main promises of precision medicine. The first one is to give pharmacotherapy and that therapeutic treatments better efficacy. So precision medicine aims to deliver tailored treatments that can optimize therapeutic outcomes, increasing the likelihood of successful response for patients. Also, it promises with fewer adverse drug reactions, and it aims to minimize adverse drug reaction, and so this is equal to increasing the safety, of course. And the third promise is to help the healthcare practitioners to take decisions that are based on the patient's specific characteristics. And this will, of course, enhance the overall quality of healthcare. So while these are the promises of precision medicine, why do this matter? Why should we care about enhancing the safety? Are we suffering any problems from adverse effects? Is there a real problem from adverse effects, or maybe response, low efficacy? Indeed, the numbers show that it's not very good. The situation currently is still ongoing, that adverse drug reactions are estimated to be between the 4th and the 6th most common cause of death worldwide. So it is still ongoing case or a need to increase the safety of medications. And it has been for a long time known that many drugs don't work the same for everyone. Like a study has shown that the proportion of patients who respond beneficially to drugs can maximum reach up to 70% to the first drug they have been prescribed. So between 50 to 70% respond to the first. So there is a response in 30 to 50% of patients. So, and adding to all of this, if we look at this map, and you identify your country. Do you identify your country as one of these in red or one of these in green, in different shades of green? From what I've seen in the chat box, I think most of us or all of the attendees of today's session are from the green areas. And what does that indicate? It shows that we have that these are the areas with the least number of studies in clinical trials. So you can see here that we all today are in areas where we receive the medications that have been tested in other places on other populations. Clinical trials, we know that any drug that to reach to our to reach the patient, it has to go through phases of clinical trials until it reaches to our to the patient, and then the post marketing phase of clinical trial. And all of these, most of these are conducted on other populations with other environments and all other resources. So how do you think if these numbers also of the adverse events and these numbers of also efficacy are coming also from populations that have been always studied? So how do you think the numbers are in our populations that are understudied? So the point of this map or the reason I'm showing this, that it's not only about the right drug or the right time and the right patient, but also regardless of the background of this patient, they have to receive the right drug that is suitable for their background. So the new paradigm or the new promise of precision medicine is moving from one size fits all. We actually gradually moved from this old paradigm into the stratified medicine, in which we have included more of the disease subtypes by understanding more of the molecular mechanisms of the disease, by understanding the different risks, by doing more studies, more observational studies. We know how we moved from one size into stratified medicine. But with time, with more data, with getting more into the genomics, the omics, the understanding the different levels of omics, we are moving now from stratified medicine into precision medicine. And precision medicine actually ensures delivery of the right intervention on the right patient at the right time, hopefully. So the reality of precision medicine is now, this is the case. Despite all these promises, it is not commonly adopted worldwide. And the challenges of adverse drug reaction are still ongoing, as I've shown you that the numbers that I have just showed in a few slides before, it was from a study in 2022, so it's only 4 years ago. So there is a simple truth that we have to keep in mind while we are going through this talk, that variability is the norm. And understanding this is a fundamental principle in for giving or providing an effective patient care. And we should keep this in mind, so it will show us, or it will create with us the need for more personalized treatment strategies, and to consider the importance of personalization or personalizing therapy. So let's here differentiate between what precision medicine is not and what it is. So precision medicine is not just genomics and advanced technologies that cost a lot of money. So usually precision medicine is misunderstood and is taken or looking at as a hype because of associating it with high costly technologies that they need a lot of money, and is it a good investment? Actually, precision medicine, it should not be put in this frame. Precision medicine is using relevant biological and clinical information to tailor treatment decision. It aims to optimize patient outcome and outcomes to the whole healthcare system through a personalized approach. So we all, as most of the attendees here are pharmacists and from the medical field, maybe, all we know that how complex is drug response. Drug responses usually are influenced by a multitude of factors, including genetics, environment, and clinical history, which highlights the need for a comprehensive understanding in precision medicine, rather than concentrating on one or a few factors. So in this scenario, where pharmacogenomics fits? Pharmacogenomics in this scenario is not everything. It's just a fundamental pillar in this. So it is a fundamental pillar, so that precision medicine cannot stand without this pillar, cannot start or evolve without this pillar, but it's not all about precision medicine. It's not all about pharmacogenomics. But if we don't establish, or we don't start from this point, and you can imagine it as the low-hanging fruit in precision medicine. That's why it's very important to keep concentrating on understanding and implementing what is possible, what can pharmacogenomics provide us with to move further with precision medicine. So it enables healthcare professionals to make informed decisions tailored to individual patient needs. This is how pharmacogenomics play a role in precision medicine. So why pharmacogenomics works? Because it is a pivotal advance in medicine, provides actionable insights. And here, let's focus on the word actionable. So the main thing is, okay, what if I know this data, but I can't do anything? If I can't, it won't affect the drug choice, or what if this, okay, I know that this is the reason of this disease, but what if I can do nothing with this reason? This is something that is unactionable. But what's good in pharmacogenomics, that it gives you something that you can act upon. And here I will show some of the evidence in the next slides about this, but using pharmacogenomic testing can help into increasing drug efficacy, reducing toxicity, and of course, improving patient outcomes. So, which is the core of precision medicine. So, if you are asking by now, what is the evidence that pharmacogenomics really works? We can look at this question from three point of views, or from three corners. Let's start with safety, and then move into efficacy, and then move into the cost, which is mainly one major concern in healthcare systems. So, is there enough evidence for pharmacogenomics that it can improve safety? So one of the latest studies, and one of the largest studies that proved the significance of pharmacogenomics in improving safety, was published in the Lancet journal, one of the most prestigious journals in medical field, in 2023. It included around 7,000 patients from different European countries, and it showed it actually divided the patients into two groups, and where the patients were either treated after pharmacogenetic testing or treated as normal, as conventional practice, and then the same cohorts were flipped. So it was like a long study. It has been it was a long study, and it included multiple medications from different drug classes. And from this study, it was shown that patients who underwent pharmacogenetic testing had 33% lower risk of experiencing adverse drug reactions than those who didn't receive pharmacogenetic testing or who received the standard care. So this is one of the most recent evidence of large studies that showed drug safety, the increasement of drug safety after pharmacogenomic testing. But actually, this has not only since this, it has been for a long time, almost 10 years for some medications that have really shown, and some gene drug medications, that there's a very strong evidence that you need to genotype or to test this gene before taking this specific medication. A study goes back to 2016, so it's 10 years ago, showed that in DPYD gene testing, it's a gene that encodes for an enzyme that detoxifies fluoropyrimidines. And a study that included more than 2,000 patients showed that the genotyping or testing only this gene can reduce the toxicity of these medication or these cytotoxic drugs from 73% to 28%. And the occurrence of drug-induced fatalities was reduced from 10% to 0%. This evidence has been there in the literature for 10 years. And just last, I think it was in November or something late 2025, this has been added to the label of one of the fluoropyrimidines affected by DPYD. Can you imagine? It has been 10 years for this to be added to the drug label, for requirement of testing DPYD for before start taking capecitabine, one of the fluoropyrimidines. So we go, so the answer of, is there enough evidence of safety? I think it's yes. Is there enough evidence for pharmacogenomics for improving drug efficacy? This is also has been proved for many long years, so for many years. It has been since 2010 that there's an evidence that tacrolimus, one of the immunosuppressants commonly used to prevent transplant rejection. So it's not like something that is over the counter, not something that is a very important medication for a very critical indication. And so here, usually it is a therapeutic drug monitoring, the common practice. But for this study, they have tested starting before the initial dose, doing a genotyping of one specific gene that is, of course, encoding for an enzyme responsible for tacrolimus detoxification, which is CYP3A5. And the results showed that for patients who have a pharmacogenomic testing at the beginning of the treatment, 75% of these patients achieved target tacrolimus concentration on day 8 compared to day 25 of patients who didn't receive this test before starting the medication. Also, they found that more patients achieved the therapeutic tacrolimus levels after 6 oral doses. So also it's 43% compared to 29% in the pharmacogenetic tested arms. The last also a result from this study that fewer doses needed to be modified. So can you imagine the number of modifications these patients needed? In the pharmacogenetic testing arm were 281 compared to 420. So it has been a very important addition. It didn't cancel the need for therapeutic drug monitoring, which is the common practice, but at least it's lowered the amount of suffering, the amount of the days that these patients needed until they reach the target of this treatment. And we are again, speaking about a very crucial indication for a very severe case, which is transplant rejection. So I think you are now convinced that that there is evidence of pharmacogenomics that it can improve efficacy, and this has been for 16 years reported from this day we are talking about. So maybe by now you said you are thinking that maybe it's the cost. Why is it cost effective? And what do we mean by cost effective? It doesn't mean that it doesn't cost. Of course, it costs money. But does the money we are paying goes back to us with an effect or a benefit that is okay, that is better than what if you don't pay this money? Actually, to answer this question, a study conducted in 2016, also 10 years from now, found that testing only CYP genes, only the cytochrome P450 genes, the ones that are most commonly tested, CYP2D6, CYP2C19, and maybe CYP2C9, at elderly patients. And when we are talking about elderly, so you have to think directly about polypharmacy, right? And when you're thinking about polypharmacy, you have to consider how vulnerable these patients and how they can benefit from taking the least number of, or the least number of trial and error. So in these 250 elderly patients, they were matched to non-tested 820 patients. So the total number of study is a little bit more than 1,000 patients. And these 200 proved that pharmacogenetic testing is associated with a saving of cost of around $218 per patient. So the amount of money you're paying for this, or that was paid for this test preemptively before starting, has resulted in a reduction of the cost of trial and error, of hospitalization due to adverse drug effects, of shifting from one medication to another until reaching the correct medication. It has actually saved money rather than cost more money. So is it cost effective? Yes, it is. Is the evidence there? Yes, it is, and it has been for a long time. And actually, there are more recent studies. I wanted to show you that this is already there. It is already there, and it has been already there for many years. We are not talking about something that we are just trying to prove that it is safe, safer, more efficacious, and also more cost effective. We are not trying to prove this. We don't need to spend time on proving this. This is the main message of bringing these results. So by now, I think you have a little bit of understanding, or a deeper understanding, of the possible impact of applying pharmacogenomics and how can it actually contribute to what we call precision medicine, which is the topic of today's talk. But to make this more relatable to you, I'm bringing now two stories. So let's start with the first story. And these two stories are actual clinical scenarios. For the first story, I don't have the name in the publication. It was not mentioned, but it is also a case scenario. A 50-year-old woman walks into her doctor's office in pain, sharp stabbing pain around her left cheek that feels like electric shocks. The diagnosis is trigeminal neuralgia, one of the most painful nerve conditions known. Actually, the treatment, her doctor prescribes carbamazepine, the standard and trusted treatment in this case. Within days, her pain begins to fade. For the first time in months, she can smile, eat, and sleep normally again. Happy ending. Actually, it was not. What happened? Weeks later, things have changed. Why? Because pain was replaced by something far worse. Her skin becomes blistered, her lips swollen, her body covered with painful rash. She is rushed to the hospital and diagnosed with Stevens-Johnson syndrome, a life-threatening drug reaction. So, given this scenario, what went wrong? Please take a moment and write your answer in the chat. What do you think went wrong with this patient? I'll open the chat box to see what you have replied. I'll just give 1 minute, so you have time. You can take your time and write your chat. Just maybe drop a word, whatever comes to your mind. What happened? What's wrong in this case? And do you think it can explain why this drug reaction happened? Adverse reaction. Okay, allergic reaction, you think? Okay, because of the gene. Which gene? Slow metabolizer. Okay, and adverse drug reaction to carbamazepine. Yeah, adverse drug reaction. Excellent. Metabolizer, maybe. CYP3A4. Okay. And adverse drug reaction, CYP gene, ADR. Okay, we have excellent students over here. And excellent audience. Okay. Okay. So many of you got it right, and actually this is the case. So indeed, what happened is that the patient was from Han Chinese descent, and the answer was written in her gene. Actually, she carried a variant called HLA-B star 1502. So it's not a metabolizer. Okay, I think that I have guided you through this by starting with or mentioning only cytochrome P450 enzymes a few slides before, but also the HLA-B star 1502 is a very well-known allele that interact with carbamazepine, and it makes it very dangerously toxic. If her DNA had been tested before prescribing, this reaction could have been completely avoided. And it's very well-known information that this allele is very common in East Asians. So indeed, a pharmacogenetic test could have guided her doctor to choose another safe and effective medication. And this is the heart of precision medicine. It's not predicting, but preventing a harm that is avoidable. And this is not a new information, because it has been for long known that East Asian, it was described earlier as an idiosyncratic reaction. But currently, we know that most of these have some genetic basis, or most of these are related to pharmacogenetic variants. So in 2011, HLA-B star 1502 has been conducted in around 5,000 patients from Taiwan, and those who had positive results. These were actually, I think these are not patients. These were normal individuals or healthy individuals. They were just given a warning that for those who have positive results were recommended to avoid carbamazepine whenever they need it in the future. After 1 year follow-up, the incidence of Stevens-Johnson syndrome was 0. So what? It's compared to the normal rate of this event or interaction or drug reaction in Taiwan. The normal rate of it is 2.3 cases per 1,000. So if you can calculate this normal rate, and that is very common in Taiwan, to the 4,877 patients that were or individuals that were included in the study, we conclude that 10 cases of this devastating adverse drug reaction were avoided by a simple test, by testing only one allele, not even the whole gene, not even the whole HLA-B, only testing the allele. Is he the carrier or not? So I think an important lesson that we can see from here, that or I hope that this lesson you get this lesson from the first case I have illustrated here, that pharmacogenomics data alone is not enough, because interpretation and actionable insights, taking action according to this. Okay, so this is a patient from an ethnicity that has high rate of this allele. So why didn't the doctor ask for this simple test before? Is it a new information? No, it's not. It has been there for many years. So the main lesson here is to take the action, to understand and interpret the results by taking an action. So my second study is even more sad. My second story is for a sad story for Dr. Anil Kapoor. He is a respected urologist and head of transplants unit at the St. Joseph Healthcare in Hamilton, Canada. He was diagnosed sadly with stage 4 colon cancer early in 2023. Diagnosis was serious, but his doctors were helpful, actually. So the plan was to begin with the standard chemotherapy in his case, which was 5-fluorouracil at this institute, which has helped countless cancer patients for decades. Actually, like many patients, many hospitals do now. Maybe by now you have concluded, okay, maybe he was not tested for DPYD. No, happily he was tested for DPYD. Dr. Anil underwent genetic pre-screening, including DPYD, and which is to check for common DNA variant that can make 5-fluorouracil, which is one of the fluoropyrimidines I have just talked about a few slides earlier. And his results came negative. So he doesn't carry these variants. So the doctor was confident in starting the treatment, and it was started. But within days of the very first dose, everything has changed, because Dr. Anil began vomiting, developed severe mouth ulcers, suffered uncontrolled diarrhea, and his condition deteriorated very rapidly. Despite the intensive care, unfortunately, he died only a few weeks later. Not from the cancer, but from a toxic reaction to 5-fluorouracil. Okay. So now you come to me and ask, okay, Dr. Zeina, what do you want from us? He was tested for DPYD, and still he got a reaction from 5-fluorouracil. So what do you think in this case, what went wrong? Also, I'll give you 2 minutes to write your answers on the chat, and I'm waiting for you, for your answers. So he was given 5-fluorouracil, and he was tested for DPYD. So Mary is suggesting that maybe another gene is responsible. The metabolites of 5-fluorouracil. Okay. The sensitive gene is present. Actually, to be more precise, we all have this gene, of course. But the variant that was tested, it turned for him as negative. So Elaine suggesting another gene that has caused this. Responsing gene located, wrong interpretation of the result. Janet is suggesting toxication from 5-fluorouracil. Okay, but 5-fluorouracil, actually, it's mainly metabolized or detoxified through DPYD. The results were not well interpreted. Okay. False negative, metabolized, normal genes on paper doesn't guarantee normal DPYD enzyme activity. Okay, good suggestion. Might be the metabolite. Okay, so if the metabolizing enzyme, if the gene that has been tested turned to be negative, drug-drug interaction, it's possible, but it was not the case. So thank you all for your answers. And this is actually what happened. After his death, further testing revealed the truth. Dr. Anil carried a rare variant in the DPYD gene, one that prevents the body from properly breaking down or detoxifying or detoxification of 5-fluorouracil. But because this specific variant isn't part of the standard pre-screening panel used in Canada, and as you can see, maybe, or as you have maybe figured out until now, I think Dr. Anil has some South Asian descent. So this is a rare variant that is not included in the common panel, because when you test for a panel of tests, or when you go back into the commercial panels, you will find that these include the variants that are more common. But let's remember that map that I showed you earlier. Who do you think these common variants refer to? To those most commonly studied populations. So if in this case, if the full genome or the full DPYD, the full gene has been tested, it could reveal this variant and it could save his life. But because we are using just the common variants, those who are commonly studied in common population, so we are here referring to something very crucial and very touching all of us here today, which is the underrepresentation. So here we are focusing on the diversity gap. The underrepresentation of diverse population in precision medicine data leads to significant concerns about how the efficacy of the drugs is going, or equity and getting the benefits of therapeutics, how it's impacting the treatment outcomes and healthcare trust for those who are treated with protocols that were not optimized to their maybe rare variants or to their rare or to their genetic background. So here we have a problem, but hopefully for each problem we have to focus on the possible solution. So these stories are not rare accidents. They are symptoms of a system problem. Actually, we have to consider precision medicine as a system. Precision medicine transcends individual tests and tools, and it requires holistic education, guidelines, and support systems to effectively guide clinical decisions and build trust in patient care. So from now on, so I hope that until now I'm building on you the appreciation of what are the potential of pharmacogenetic testing, but in between you are maybe thinking that, okay, but what if I am in a country that this is not even applied or not even thought of as something? Let's look at what is your thought about which country has the best implemented pharmacogenetics program right now? What do you think the most or the country with the most established pharmacogenomics program? Can you drop it in the chat? USA, America, okay. Okay, all of you are guessing the correct answer. United States, it's widely regarded as the leader in clinical application and research, and has a high number of approved actionable pharmacogenomics label in the FDA, the American Food and Drug Administration. It has the home of the CIPIC, the Pharmacogenomic Implementation Consortium, who provides evidence-based guidelines for integrating testing routine care. Okay, so this is the case right now. So do you think that, or after all this evidence I have illustrated, all these studies that have been there for many years, all these recent studies that have proved that they are kept holding, the evidence is keep holding for many years. What do you think the situation in United States, the most, as you all know, that it's the best implemented, it has or it hosts the best implemented pharmacogenomics program? Unfortunately, this is a paper that was published only in October 2025, so it's less than 4 months ago. And it showed by surveying around 29,000 patients, so it's a huge sample, that pharmacogenomics uptake remains extremely low in the USA. Only 6.6% of adults were tested in the USA with the best implementation programs in pharmacogenomics, despite the strong evidence, despite the reimbursement, and the national precision medicine initiatives. So, and when they analyzed the results or the reasons for this, they found that the demand is weak. Nearly 2/3 of the untested adults don't want pharmacogenetic testing, which reveals actually a major awareness and education gaps. And if this reflects the community, it also reflects the huge effort or the huge requirement from the healthcare workers to introduce this education in the correct way and to increase the awareness. Also, it was found that clinical integration is not complete because less than 50% from those who received these results actually understand the results, and only between 1 in 5 that have already received a pharmacogenetic guided medication changes. So it's not only those who don't want to test because they are not aware of the importance of testing, also those who that the clinical institutes that conducted the test didn't get back to the patient with the explanation of their results, because otherwise the patient would never understand it without the interpretation of the results, without explaining, without a right post-test education. So the gap is still there. Should we look at this as a problem? Of course. This is it's not only a single problem. There are multiple struggles here. So precision medicine faces significant barriers, including fragmented data, limited clinical readiness, and limited experiences. However, successful people look into problems as gaps to fill. And if you are here today, so you are interested in research in precision medicine, so you have to think, okay, I understand now the problem, I know the gap, how can I contribute to filling this gap? Implementing precision medicine in clinical setting requires a deep understanding of evidence, integration consideration. So how can I learn from the experiences of those who tried to implement and didn't do it or didn't reach to the full potential of the implementation? How can I give this or how can I get from their experience to apply to my country, to my health institute, to my place where I am practicing? And I have to keep in mind that whatever interpretation, whatever change in the healthcare system needs, that you have to work on adapting this and ensuring that it won't affect the workflow of your colleagues in the healthcare practitioners. So what I can see now, and I hope you see with me, there is an opportunity for you. It's not a problem to stop and like being paralyzed in front of it. It's a great opportunity. And we have one major opportunity or one major advantage right now, which is technology. Actually, technology plays a crucial role in supporting precision medicine and in accelerating its adoption. AI and big data can enhance clinical decision-making enormously, and you are as equal to all these problems. We have now a huge advancement that can accelerate solving these problems and tackling these hurdles. So as we move forward, the integration of precision medicine into everyday practice will take precedence, focusing on maturity over the hype and practical applications in patient care. So this series, which I'm opening today, is one of these. I hope you take it as a very excellent opportunity to delve into the key aspects of precision medicine, exploring clinical applications, technology roles, ethical consideration, and real-world implementation challenges for you and all the young pharmacists or practitioners and professionals worldwide. So my key takeaways is that precision medicine is not just a trend or a hype, it's about preventing unavoidable harm. Pharmacogenomics already works for safer drugs, better outcomes, and lowers the costs. The real challenge today is implementation, increasing education, and I'm happy that you are here today just starting with this, with the education and equity. And this is a very important thing that you have to keep in mind, that it's our responsibility as population living in areas that are underrepresented in research, that we have to work on this area, because it is our responsibility to improve this or to bridge this gap. The future of precision medicine depends less on new discoveries and more on how we apply what we already know. And I hope that you got this from all the old studies that I cited. So I would end this by a question that I leave with you, or I leave you with. If evidence is strong, technology is available now, patients are still being harmed. So why isn't pharmacogenomics a routine care yet? And more importantly, what can be your role that you can play in changing this current situation? I hope you keep this question in your mind while I end by a few final thoughts. You don't need to be a genetist to advance precision medicine. You should only ask better questions. You should recognize variability between patients that you are dealing with and advocate for safer prescribing and help translate evidence that is already there into everyday practice. So with this precision medicine, I want to end my talk by precision medicine will succeed only when future professionals like you can choose to use it. And I hope you enjoyed this, and thank you for listening, and please stay in touch. If you scan this QR code, you can get all the information to stay connected with me through my LinkedIn account, my email, and my website. Thank you.
Amazing, 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 amazing. Dr. Zaina, I think perhaps some persons may still love to scan that. So
Okay. Yeah,
please,
sorry.
yes. If you
Yeah,
could take it up. I think a lot of persons would want to connect with you, please. Thank you so much. I can see the excitement in the house, and I know that today's session, as always, has been an amazing one. Thank you so much, Dr. Zena.
Thank
I
you.
understand already that it should be like around 11 p.m. at your end. So we're going to move straight up right now to the Q&A session. So if any one of us has any questions to ask, I perhaps should have said we should drop them in the chat box before now, but we're going to do it this way. So if you have any questions to ask, you just raise your hand. Use the raise hand feature you can see on your screen. Just raise your hand and you'll be called upon to ask your questions. So we're going to take a couple of questions depending on how many of the questions a speaker can take. And like I mentioned earlier, I believe it should be around 11 p.m. at her end. So she would have to go rest. So let's take some couple of questions. Let's just see the hands. If you have any questions you want to ask, I think I do have some questions myself personally, but we're going to keep that till the end. Let's have questions from the participants first.
Yeah.
So if you have any questions, just do by raising up your hand and you would be unmuted.
Thank you all for the kind
Okay,
words. Happy to
Ayman,
do it.
there you
Yeah.
go. You're welcome, Dr. Zaina. You're welcome. Always a pleasure. Ivan, please, you can
So,
unmute.
so how can we implement it in a poor country? Like they cannot afford the facilities, na? Like because the this process is expensive. So how can we implement it for a poor country?
Excellent. Thank you. Thank you, Ayman. So actually, this is a very frequent question that I have been always receiving, especially when I'm talking to or when the audience are from countries from around the world, from the underrepresented population again, populations. So indeed, as I've mentioned in my presentation, that it is a systematic problem. It is a systematic. Precision medicine is a system that should be implemented. So we have to show the governments and the decision makers that it is cost effective. You are going to pay money to get back reduction of cost of healthcare. You are avoiding trial and error. You are avoiding hospitalizations. You are reducing the costs of wasted medicines. It is a sustainable approach. It's just the cost effective. And when this is implemented or when we show this evidence to the healthcare decision makers, in this case, we can get into the reimbursement. We can get support for the reimbursement from maybe the insurance. Maybe we can go into the lower cost practices, like, for example, and this is an example that I usually use, when COVID-19 has struck, when we had the pandemic, all the countries out of sudden have reduced at the beginning the cost for real-time PCR, which is the main test that was used for detection of the virus, has started very expensive, and then by time it's reduced too much, and it became very common in many labs, and they got the equipment for this. So real-time PCR, it's all what you need to do genotyping for a variant that is known for this for in this gene, in this specific gene. So it should be just the same cost as COVID-19 test. Why we are keeping this as a barrier? That the cost, it will be cost after all of this evidence. If you are not convinced that it's cost effective, okay, just do the most common variants by a simple method like real-time PCR that you already you had already experience with offering it to the public in lower costs when it was needed. So it's not about money, but about convincing the decision makers that it will reduce the costs. Whatever you pay here, it will get back with reduction, and it is cost effective. I hope I answered your question.
Yeah, thank you so much.
Thank you, dear. I think, but Badimosi is raising her hand. Please.
Can I ask another question, please?
Okay, go ahead.
Like as you mentioned, and Dr. Anil case that he passed the same process and he was not present at that gene. So at the end, he died because of another gene. So don't you think that we are searching for only one gene and we are doing the whole procedure for only specific gene, and the person is died because of another reason? So does it will help, like pharmacogenomics will help in this case?
Actually, it will help, but of course it will help if it would have been only if the whole gene has been covered because it's just the same gene. We know now how this medication is metabolized. We know that which genes are involved in them in each drug metabolism. But the thing is, for some genes, we are just targeting the variants, so we are not covering the whole gene. Okay, so the selection of variants is coming out of the studies that have been conducted mainly on Caucasians. Okay, even if you want to be there, there's an increasing data coming from other populations other than Caucasians, like Asia has been covered more and more increasingly, and recent in the Middle East. There are some also projects, but for each population there should be at the population level, there should be projects that investigate or explore what are the variants more common, how can we customize our pharmacogenetic testing to our population and make it and not adopt it as it is commercialized, but maybe first before that like testing it on our population and investigating, is it enough? Do we need to add more variants? Do we need to add other genes? Do we have actually do we need to test for this gene if we have very few cases, or it has never been proved to be relevant to our population? So this is the solution. Actually, it should be something from at the population level, works population by population, and even in the populations that are multi-ethnic, it should be considered the different ethnicities. So I hope I answered your question. Can you, Badimosi, please, sorry for mispronouncing your name. Can you turn on your mic and ask your question?
Okay. Can everyone hear me? Can you hear me?
Yes, we can hear you. Go ahead.
Okay.
Go ahead.
For Zeina, so you really, it's an interesting one listening to you so far. So I'm a biomedical engineer by profession with strong interest in digital medicine. So, and according to what you have shared with us, I felt that it really goes well and we have to do more in some certain aspects. So I'm asking that how, especially you shared for us a graph the other time, the green graph, that in this particular zone, how do you think that digital medicine will be able to help in terms of precision medicine? So that's my question. So the aspect that maybe we need to do more so that we'll be able to help in precision medicine field. Thank you.
I'm not sure that I have understood your question very clearly, because the voice is a little bit not clear. But I guess you asked how can we go from for some medications.
No, how can we use digital medicine? Digital medicine, how can digital medicine help? I don't know if you hear me. How can digital medicine help in terms of
Digital medicine.
maybe in order to
Did I
digital
get you
medicine?
right? I'm really sorry, but because your that the voice is not very clear. Destiny, if you can help me.
Okay, yeah. Yes, I think yeah, his voice is not really clear, but I think he's asking about digital medicine, how digital
yeah.
medicine can help. Yeah.
Excellent. So actually, this is the promise of the technology that I have hinted to in my slides, and digital medicine is it's just a window to make things faster. So we still need research, we still need local data, but whenever you get back with the data and apply it through digital medicine, so you are accelerating the adoption. You are getting the evidence that this work will not interfere with the workflow of the practitioners. This will you will get the results explained clearly to the with the digital tools to the patients. So all of this, it's all like a circle that complete each other. So I think it's just in the middle of accelerating the adoption of precision medicine. Thank you, and I'm really sorry for not getting or hearing you clearly.
Okay,
Okay.
amazing. Just before we take Abraham's question, just to let us know, I just dropped the attendance register in the chat box. So you can just, while we take the questions, you can just use the attendance register to sign the attendance for today's session, because that's going to be part of what we'll use for the certificates. Okay, so let's take from Abraham. Abraham, you can unmute and ask a question.
All right, much for the presentation. I really agree. So my question is it possible to integrate pharmacogenomics and AI? And if it is, how is there any way, if it is, like, what are the opportunities of mix?
AI integration into pharmacogenomics. Excellent question. Thank you, Abraham. So for me as a researcher, it has been very clear from day one that bioinformatic tools have not been designed for pharmacogenomics, because bioinformatic tools, for those who are with some bioinformatic background, would know that the basis of predicting the variants and their effect is if this variant is pathogenic or not pathogenic. But the problem in pharmacogenomic testing is that it is the variants here are not disease causing. So all the bioinformatic tools have been built on the hypothesis that doesn't apply to pharmacogenomic testing. That's why it has been taking long time for pharmacogenetic bioinformatic tools to be developed. And just recently, these have been evolving, and all of this because of this gap between those who are in the labs and those who work in the dry labs on the computers. So if you are in the field of AI and in the field of with some bioinformatic or informatics background, you are just in the right place now to use these advances in AI to accelerate the process of understanding the pharmacogenetic variants, also in contributing to building guidelines that are population specific, and that are because AI is just fastening everything and every process, making coding easier, making everything easier and faster. So it's just the right time, because we have been waiting and this data has been there for many years. And the main problem is this gap between those in the lab, those who are producing the data, and those who are using it and making sense of it for the practitioners. So I think AI will just fasten bridging this gap. Next question. I hope I answered your question.
Amazing.
Thank you.
Amazing. Yeah, okay. I think I see admin. Is that the name, admin?
Hello, I'm Duncan. So my question is, I was asking on how feasible is precision medicine and pharmacogenomics in our current setup, mostly possibly if we talk of African countries. When we talk of numbers of maybe machinery that is required, the number of patients that can be served per machine, at what rate, frequency, and all that. And then maybe of talking about the cost and everything that could be, how feasible is it, where are we at the point, and how possible that, how can we really maybe reach to the point where we can say it's a thumbs up.
Okay, so excellent. So I know it's not it's not the easiest place to be, where your country is suffering from a lot of healthcare priorities, and there are multiple priorities before genetic testing. But if you start from now by educating yourself, increasing the awareness in the public about this issue, that many of these toxicity cases, adverse events are avoidable, and increasing the bringing the evidence that this to the decision makers, that this can reduce the costs of healthcare. By this, we can maybe raise the budgets for adoption of precision medicine practices and pharmacogenetic testing. I know that talking is easier than doing, but if we don't start by ourselves, if we don't select the gap that we can fill in this complex problem, so we will stay in our places. And we have now the ability, if you are here, so you are starting, if this is your first time to hear about pharmacogenomics and precision medicine, so you are on the beginning of your education journey, go ahead. And whenever you are learning and growing, take someone with you that can grow with you also, and disseminate knowledge, also spread awareness. And I know that by all of this, if we have increased the number of people who are aware of this, and we can encourage our governments to take these initiatives as something that can enhance all of our healthcare systems and will prove cost effective. I hope I answered.
Amazing. Thank you so much, Dr. Zeina. Just to say a few things about that. Yes, awareness is really a big issue, and as a matter of fact, I was in my I told you about my clinical posting, Dr. Zeina, that I'm currently having my clinical posting, and just days ago, I was with my pharmacy preceptor, the HOD of a pharmacy at a hospital where I was posted to. And I told him about my interest in going for an event that was happening in my university, which was a research conference that was hosted by my university. So I told him about going for that research conference. And then he asked me a follow-up question of, oh, why do you want to do research? Why are you so interested in research? Your mates are they're in the world, and you're thinking of going for a research conference. And then he now asked another question about, you seem like someone that has everything figured out. Do you already know what you want to do in the future? And I just told him, oh, I'm interested in pharmacogenomics. Of course, I have everything figured out. But I'm interested in pharmacogenomics and precision medicine. And he was like, what's that? Pharmaco what? And I was surprised. Yes, I was surprised because this is the head of the pharmacy unit, and is a pharmacist with many years of experience. So the awareness thing is not really something that we talk about when we just talk about people in the market or people who are not in the medical space. We're talking of pharmacists, we're talking of medical doctors, we're talking of nurses, a good number of them who do not know about pharmacogenomics. And they're not knowing about pharmacogenomics directly implies that they would not know the benefits that it could have on the healthcare space. So it is a great problem that we have at hand that we'll have to solve. And one of the things that I think we've begun to do in this respect here at PharmaGenoXfE is we recently launched an ambassadorship program, and what we are targeted at doing is around this awareness problem, solving these problems, making the knowledge of the participants in this webinar series, and you're interested in joining that global ambassadorship program, kindly reach out to me. We'll do well to ensure that we have a very, very great and fantastic program for all of you, so as to ensure that we all put our hands together to contribute to ensuring that pharmacogenomics, the message of precision medicine, get to every nooks and crannies of the globe. So I understand that the deadline for application has expired, yes, but I'm opening it now as a grace to those persons who may not have applied for that opportunity. So if you are interested, do well to reach out to myself or to any of the admins after this session. All right. So I don't know, Dr. Zeina, should we call it a wrap now? It's really late now, at least at your end.
It's okay if we can take one more question and
okay. That's really
question.
nice. That's really nice.
Okay.
That's really nice.
Last question, yeah.
That's really nice. I think I saw a question in the chat box earlier. Since no one is raising his or her hand, I saw a question about, asked this question, or she has asked this question already, but let me just read. It says, I see that precision medicine is a lifesaver. So are we going to let those population in low-income countries to die as they can't afford implementation of precision medicine? Oh my God. And what can we do as young person to improve or to help something in precision medicine implementation? Okay, what can we do basically as students to help in precision medicine implementation? I think that's his question or her question.
Yeah. So the question, the answer in short, as I have mentioned earlier, is education. So you have to contribute to educate. You have to educate yourself and also spread awareness. Sorry. Sorry, Destiny, because you didn't read, yeah. So indeed, it's about increasing your education, getting more involved in the field. As a student, you have now free time that you are not sure that you will get it after you finish and graduate and start working. So use your free time and getting involved more and understanding more, learning more about these. You are just in the right time where you can get information. Information is there all over the world. There's no need to it's available. There are visit my website. You are welcome, and also you can go to the ClinPGX, which was used to be known as PharmaGenoXfE. So ClinPGX is a hub for everything you need to learn about pharmacogenomics. It has many educational resources. You can see there, you can reach there to the guidelines. So educate yourself and try to spread awareness and education in this field. And this is the least you can do as a student. And when you reach to the work and when you reach to the practice, you have to keep these lessons that you have learned during today's talk and what you have learned on recognizing how can I do this in my job? How can I practice this in my job? Okay, Destiny.
Amazing. Thank you so much. Thank you so much, Dr. Zeina. Thank you so much. Thank you so much, everyone. It's been a very, very, very impactful session. You can agree with me on that. I see someone asking about reaching out regarding the ambassadorship program. Any of the admins on the WhatsApp group, just reach out to any of them and just perhaps drop your name and your interest in joining the program. So we would follow it up from there. Thank you so much, everyone. Thank you so much, Dr. Zeina. Especially great thanks to you. You know, I did reach out to a lot of speakers during this period that we organized this webinar series. And, you know, one of the speakers that I would always reach out to and would always say yes. And in fact, it's just so amazing to see that each time I reach out to Dr. Zeina, it's always a yes. It's always a yes. Oh, I'm very glad to do it. I'm very glad to do it. I'll be very willing to do it. And it speaks a lot to how generous and very committed to precision medicine and pharmacogenomics, as well as clinical healthcare in the large space that Dr. Zeina is. Thank you so much. We are very grateful. Thank you so
Yeah.
much.
Thank you for your invitation.
Thank you so much, Dr. Zeina.
Okay, goodbye.
All right, so good night, everyone. The next session for series, I understand that, of course, we know that this is the first session for the entire series, which is a nine session series. So the next session is going to be publicized. We're going to be sharing the details of the session via your registered emails and the WhatsApp groups. We're going to be sharing it on LinkedIn as well. We've not been very loud on LinkedIn lately. Of course, that's been as a result of so much work to do. So we're going to be sharing the details of the next meetings so that you are aware and you equally are here to participate. So good night, everyone. It's been a very nice time with all of you.
Thank you. Bye.
And do not forget to sign the attendance. Do not forget to sign the attendance. Like we mentioned earlier, we are all going to be required to make 65% of the attendance of the entire series to be eligible for the certificate. Okay, someone says you're not on the WhatsApp group. You should have the WhatsApp group link was included in the registration link, the registration form rather. So you probably should have seen that or you missed it while registering, but no problems. We'll try and send the link to the WhatsApp group during the next publication we're going to be making via the registered emails, the emails with which you registered. We're going to be sharing the link to the WhatsApp group via that, via our next publicity. So you can be sure to await that and join then, because we also share a lot of information on the WhatsApp group. Okay. Okay. Attendance form. Oh my goodness. It's been shared a lot of times now. I just shared the link again to the attendance. Do well to fill it, and we're going to be sharing it in the WhatsApp group as well. So good night, everyone. Have a nice day.